Good evening, everyone. We are going to discuss chest pain, the Canadian approach to chest pain in neck OSCE. Um, the goals for this sessions are uh, for you to be able to use safe, time-critical neck OSCE approach to chest pain, identify and prioritize the six can't miss diagnoses, order and interpret first-line investigations, ECG, troponin imaging using Canadian pathways, and start initial management for acute coronary syndrome, pulmonary embolism, aortic syndromes, and pneumothoraxes, and be able to communicate disposition, safety netting, follow-up like a Canadian OSCE examiner expects. Now, let's begin with chest pain, the rules, approach rules. Anytime you encounter chest pain, think of life-threatening conditions first. And until you prove them, you have to consider them. If you prove that they are not present in the patient, you can say, okay, chest pain is from another source. Now, once you enter the station and you see that the patient's history says that patient is here for chest pain, in the first 60 seconds, make sure you assess ABCs, airway, breathing, circulation. If patient is talking to you, airway is fine. Breathing means taking a listen to the chest. You can do it directly, or based on their oxygen levels, you can say patient's breathing seems to be fine. They are not breathing with effort, or they are not using accessory muscles. Full vitals, make sure you ask about vitals as soon as you enter. You can introduce yourself, ask the patient what's going on. They will say, I have chest pain. And then you can say, do we have a set of vitals for the patient? If it's in a hospital situation, you would attach monitors, but in OSCE, monitors may not be available. So you just verbalize that ideally, I would want the patient attached to a monitor. Open IV access. We want two IVs on both arms, large gauge IVs. Maybe this patient needs resuscitation and as a fluid administration. So in that case, IVs are very important. And our goal is to get an urgent ECG. If anyone here has worked in a hospital in Ontario, you would know as soon as a patient comes in for chest pain, the priority is to get them to an ECG. They get an ECG first, and then other things can be done later on. If patient is unstable, you start resuscitation. Oxygen for hypoxemia, fluids, pressors, treatment of arrhythmia, call for help. Do not delay resuscitation for history taking. Now, in OSCEs, the goal is to state your priority differentials early, justify them, then show time critical actions, ECG, aspirin, pathway activation, which pathway are you going to use? We're going to discuss how to go about it. Now, if you come across a patient with chest pain, make sure you are ruling these things out first. First thing is acute coronary syndrome. Now, acute coronary syndrome, look at the patient. If the patient is older, they have risk factors, they're obese, they have history of hypertension, or if it's given, or if the pain is typical to what a chest pain in acute coronary syndrome, such as a STEMI, ST elevation, myocardial infarction, non-STEMI, or unstable angina looks like. Think of acute coronary syndrome first. Pain with acute coronary syndrome, it feels like a pressure or heaviness, and patient usually really is sweating, they feel nauseous, and they would have risk factors for acute coronary syndrome. Second thing to look for is pulmonary embolism. Now, in pulmonary embolism, the pain is more pleuritic. Patient says it feels like a deeper pain, and it's kind of when I take a deep breath in, it feels like there is tightness with it. That would be the description of pain. Patient will have dyspnea, and their such a pulse would be high, tachycardia, hypoxemia, low oxygen, and they will have risk of venous thromboembolism. Maybe it's a woman who is taking OCPs, maybe someone who had a surgery, maybe someone who had a travel that was a long distance travel. Now, Third thing to think of is acute aortic syndromes. Acute aortic syndrome like aortic dissection, intramural hematoma. These are some of the acute aortic syndromes. For acute aortic syndrome, pain starts suddenly and it reaches max point almost instantly. In patient, it describes it as when if it is dissection, patient will say it is like a really tearing pain that goes to my back. Patient may have neurodeficits, difference in pulse or BP on both arms. These are some of the findings associated with acute aortic syndrome, such as acute dissection, aortic dissection. Tension pneumothorax is another potential differential for acute chest pain. In patient with tension pneumothorax, you would see they do not have breath sounds on the affected side. They are possibly in shock. Their trachea is deviated to the other side. Their JVP or jugular vein is distended. If you see this scenario in a patient with unilateral absent breath sounds, trachea deviated to the other side and JVP raised, do a needle thoracostomy or decompress the chest with a needle, 18 gauge or 16 gauge preferably, and then go for a chest tube. If you do not decompress and wait for X-rays, the patient is going to go into cardiac arrest and potentially die. Cardiac tamponade is another differential for someone who experiences chest pain. Patient in tamponades, they usually come with low blood pressure, their JVP is raised, and their heart sounds are muffled, or you usually are unable to correctly listen to them or auscultate them. The heart sounds like it's kind of pushing against pressure, but it's unable to carry out a full relaxation and then contraction. So you would see muffled sounds of the heart. Breath sounds would be normal in this case. Esophageal rupture is another potential differential that you have to keep. But remember, for esophageal rupture, patient should be vomiting severely. It happens most of the times in people who are intoxicated with alcohol. They vomit, and then come in with severe chest pain and hematemesis or blood in vomitus, and they may have fever and other symptoms. But patient would usually be in an alcoholic who has been drinking and now they have had vomiting for the past 6 hours or 8 hours, and now they present with severe sudden onset chest pain. This is your sign to think of esophageal rupture. For history taking, again, you can use the OCD PQRST UVAA approach, or you can use another approach. For chest pain, I personally prefer the OPQRST questioning method. It is faster and sounds more natural in chest pain. For chest pains that are associated with some conditions, if chest pain comes that is suddenly at maximum intensity, it is likely to be acute aortic syndrome, like acute aortic dissection. Chest pain that feels like pressure or heaviness and may or may not be triggered by exertion. This is likely acute coronary syndrome. Chest pain that feels pleuritic and patient says my breath is catching, or I'm unable to take a deep breath. This is likely pulmonary embolism. It could also be pneumothorax or pericarditis. Chest pain that gets better with position. For example, if I bend forward, my chest pain gets better. It's likely to be pericarditis. Some associated symptoms. Now, acute coronary syndrome, patient will be sweating, they will have nausea, they may feel short of breath. In pulmonary embolism, patient may faint, they may have dyspnea, they may have hemoptysis. Hemoptysis is a late finding of pulmonary embolism. In acute aortic syndromes, back pain or pain relating to the back, neurodeficits and differences in pulse or blood pressure of both arms would be present. If patient has fever or cough with the chest pain, think of pneumonias as the likely cause. Now, In your history taking, make sure that you ask about medications. Aspirin, has the patient taken it or not? If not, give them aspirin. Anticoagulants, give patient anticoagulants. Ask about the use of stimulants or cocaine. These could trigger an ischemic attack. Phosphodiesterase 5 inhibitors, such as Viagra or sildenafil, tadalafil, etc. Ask about these because they are very important. We cannot give nitroglycerin if patient has taken any of the PDE5 inhibitors, or we are going to make the blood pressure tank and patient could collapse because of the low blood pressure. Now, for patients for the neck OSCE chest pain, if you are doing the physical exam, say what you are doing. Say, I'm going to check the patient's vitals unless a set of vitals is present. Look for fever, tachycardia, hypertension, low SpO2. General appearance of patient, see if the patient is in general distress. Are they sweating? Are they blue in color? Are they cyanotic? Cardiac exam, look for new murmurs. Jugular vein pressure, is it elevated or not? Look for new edema or signs of heart failure. Check pulses on both arms if you suspect acute aortic syndrome, and look for deficit in the pulses. Respiratory, if unilateral breath sounds are low, think of pneumothorax. Look for crackles. If crackles are present and they're in the bases, it could be pulmonary edema. If they are bilateral and in the bases, it is likely pulmonary edema. If they are focal crackles, think of pneumonias or infections. Palpate the chest wall. Look for features of musculoskeletal pain, such as the costochondritis, which can cause tenderness on the chest wall when you palpate the joint. And finally, make sure that you look for patients, you check patients' legs or assess them for swelling that is unilateral or swelling in general, because bilateral swelling in the ankles or ankle edema happens in heart failures. And look for tenderness. Patient with DVT, they will have swollen red tender leg that is painful, or patient would feel severe pain in the leg. This would be a sign that patient has DVT and their chest pain is likely because of a pulmonary embolism from the DVT. Now, imaging or investigations, our target is to get patient to an EKG within 10 minutes. Patient's ECG, first ECG should be done on arrival within the first 10 minutes, and then we can repeat it every 15 to 30 minutes or sooner if there is suspicion for ischemic event. If patient has changes in the lead 2, 3 AVF or inferior leads, do a posterior or right-sided ECG. If patient's ECG shows ST elevation in a coronary territory, meaning that it is affecting either the interior, the septal, the lateral, or the inferior wall of the heart. This is STEMI, and then you're going to activate reperfusion pathway based on what your hospital uses. Now, in chest pains, if clinically patient is not low risk, we will do serial high sensitivity troponin and ECG. We cannot say based on one value that patient is low risk and they can go home. For example, Alberta high sensitivity troponin rule is that if patient is stable and they have non-ischemic ECG, do high sensitivity troponin at 0 hour, then at 2 hours. If both are negative, it is unlikely to be ischemic pain. Patient may be discharged safely, or you can still follow them up further. If the troponins are rising at 2 hours, there are ongoing symptoms, or patient is high risk, repeat the troponin levels at 4 hours and consult cardiology. Now, in 2025, they say use the 3C concept. Single troponin does not rule out MI. Rise in troponin levels does not directly mean that patient has acute coronary syndrome. Delta-based interpretation, it means that we are going to check for the trends of troponin. Let's say we are doing multiple troponin levels and they're trending like this, but they are not matching the cutoff values. Cutoff values will depend on what assay they are using. So if they're not reaching the cutoff value, this means the rise in troponin is unlikely to be from chest pain. But if the troponins trend like this, like a delta wave, kind of a delta wave that we see in Wolff-Parkinson-White syndrome, which is a sudden rise in troponins, it means that the the patient's pain or the patient's chest pain is likely to be from an acute coronary syndrome. Now, for exam or in your OSCEs, you can say, I'm going to use the Vancouver chest pain rule. If you remember that, otherwise, this one is a bit complex. So the HEART score is more common to use in Canada. Say I'm going to use HEART score to calculate patient's risk. History, does patient have risk factors for myocardial infarction? Risk factors like smoking, high blood pressure, diabetes, high cholesterol. These are the risk factors for myocardial infarction. If patient has risk factors for 3 or more risk factors for myocardial infarction, patient is considered high risk based on HEART score. We will look at ECG, age, and again, the risk factors we already discussed, and troponin levels. And this will give us our next steps. If high risk or moderate risk, but ECG is normal, troponins are okay. In that case, we would monitor them. We would do serial ECGs and troponins. If patient is low risk based on HEART score, we may repeat the ECG and the troponins, or we can safely follow up the patient in community. Now, when it comes to management of different conditions that cause chest pain, acute coronary syndromes. Now, acute coronary syndrome, I think everyone here would remember that mnemonic MONA, right? Morphine, oxygen, nitroglycerin, and aspirin. Aspirin, first thing to give, 160 to 325 milligram based on patient's body type. If they are obese, 325. If they are very lean, then you can give them 160. If no allergy or active major bleed present, you can give them aspirin. Nitroglycerin for ongoing ischemic pain, only if systolic blood pressure is more than 90. Some places use 100, but above 90 systolic blood pressure, patient is likely not have any issues with use of nitroglycerin. Now, nitrates like nitroglycerin, we will avoid them if patient recently used sildenafil or PDE5 inhibitors. Oxygen only if patient is hypoxemic. And if patient has saturation less than 92% and patient doesn't have COPD, we will give them oxygen. Analgesia, you can use morphine, you can use other analgesics. We would try to avoid using NSAIDs together with aspirin because they can both increase the risk for bleeding. So we can use other analgesics. Antiemetics as needed for patient. If they're nauseous, give them an antiemetic and involve cardiology early. Now, contraindications for some for nitroglycerin. If patient is in shock or in hypotension, if we are suspecting right ventricular infarct, or if patient recently used 5 PDE, 5-fluorodehydrase and 5 inhibitor, we are going to stop, we are not going to give them nitroglycerin. For aspirin, active bleeding or true aspirin allergy. For exam, to be safe, you can say, I will reassess patient's vitals after giving them nitrates and monitor them for hypotension or potential hypotension. Now, pre-perfusion for STEMI. Now, Canada has time targets. Once you confirm STEMI with, if it's ST elevation on ECG, this is STEMI confirmed. What are we going to do? We are going to do primary PCI. Our target is door to balloon, less than 90 minutes. Now, door to balloon means the facility where the patient is PCI capable. If patient has to be transferred to another facility, then our goal is up to 120 minutes. For example, patient has MI in Northern Ontario, and there is no hospital capable of PCI, and we have to transfer them to Toronto. Now, from Northern Ontario to Toronto, it's a 4-hour drive or more, depending on traffic. Patient is unlikely to be within the 120-minute window. Therefore, patient is going to get fibrinolysis. If patient was to get to a hospital that was within 120 minutes from the time the patient arrived at the first facility to the next facility's balloon or cath lab, we will still transfer them without fibrinolysis. Now, for pulmonary embolism, remember risk factors: travel, surgery, females who are taking OCPs, smoking. These are some of the risk factors for pulmonary embolism. If you have a suspicion for pulmonary embolism, you are going to use the clinical stability and pretest probability. If patient is stable and you have pretest probability in, for example, Wills criteria or another validated rule, we are going to say, I'm going to do D-dimer based on probability if the probability is low. If probability is high, we are going to skip D-dimer. We are going to go straight into imaging, which is CT angiogram or pulmonary angiogram, CTPA. For pulmonary embolism in exam, assess patient stability, estimate pretest probability using Wills score or another criteria. For a quick assessment, think of it like this. Is pulmonary embolism the likely diagnosis? Or like this, is the patient's chest pain or symptoms not explained by anything else? This means patient has 3 points. Does the patient have a high risk to have a pulmonary embolism, like travel, they have a DVT or history of DVT? Then you add 1.5 more, 4 or higher than that means that patient is very likely to have a pulmonary embolism. You go straight for CT pulmonary angiogram. If patient's score is less than 4, in that case, we do D-dimer. All right. Now, for OSCE, how are you going to phrase why you're that you're going to rule out pulmonary embolism? Once you say acute coronary syndrome is my top differential based on patient's pain characters and their risk factors. Second probability or the second differential I'm keeping in my mind is pulmonary embolism. I will assess patient stability, calculate pretest probability of a pulmonary embolism, then based on the pretest probability, assess patient to get either D-dimer or imaging appropriately. Now, management of pulmonary embolism. Is patient high, intermediate, or low risk? Patient has hypotension. This is a high risk patient, and we need to escalate it quickly. For patients who have a high pretest probability, someone who has a DVT or someone whose symptoms are not explained by anything else, we are going to start rapid acting anticoagulation while waiting for imaging. Unless patient has a high risk of bleeding, rapid anticoagulation preferred with unfractionated heparin. If patient is unstable, then in that case, we are going to go through CPR, call for help, resuscitate patient, and escalate treatment as you seem appropriate. You can even send them to ICU or to cardiology unit based on what your hospital's protocols are. Now, acute aortic syndromes like dissection, intramural hematoma, other aortic ulcers, etc. These some of the red flags in the history and exam. If pain is suddenly at its peak intensity and it's in the chest and back, if there is any neurological deficit present, patient has numbness in the hand or something similar to that, patient has syncope or patient says that they collapsed, pulse deficit or differential in BP, patient's one side BP is 160, the other side is 80, then that should raise an alarm for aortic syndrome like a dissection. If you see a new aortic regurgitation type murmur, auscultate a new aortic regurgitation type murmur, then that is also a high risk feature. It means that patient may have acute aortic dissection. If patient has aortic disease, connective tissue disorder like Marfan's, Ehlers-Danlos, etc., or patient has uncontrolled hypertension, these are also risk factors for aortic dissections. Um, so for OSCE, management targets for aortic dissection would be we are going to aim for pain control, heart rate less than 60 with beta blockers, systolic blood pressure between 100 and 120 with vasodilators if needed, urgent CT angiography, and surgical consult. Surgeon in this case would be a cardiothoracic surgeon who may consider either repair or conservative treatment. Now, some of the conditions that may not give you the time to do imaging, one of them is tension pneumothorax. If patient comes with sudden severe chest pain and they are now in shock and you don't hear any breath sounds on one side, plus their neck veins are distended and trachea is deviated to the other side, this patient has tension pneumothorax, decompress. Nothing else, you decompress at the second intercostal space on mid-clavicular line. For OSCEs, if you come across tension pneumothorax, you are going to say, based on my observation, patient likely has a tension pneumothorax. I'm going to decompress immediately and wait for imaging. I'm going to decompress first without waiting for imaging at second intercostal space on mid-clavicular line or on the side that is affected, or from the side from which the trachea has been shifted away. Now, cardiac tamponade, similarly, cardiac tamponade may or may not give you time to do imaging. Patient will have low blood pressure. They will have tachycardia, elevated jugular venous pressure, and dyspnea or shortness of breath. Do a bedside echo if available, and drain urgently. Stable, unstable, drain urgently. In unstable cases, we can consider drainage more rapidly, but if patient is stable, then we can do bedside echo to find the amount of fluid around the heart. Now, in OSCEs, I will call senior or ICU and prepare for pericardiocentesis if unstable. But in real life, if you are working in an emergency room, you may not find the time to call them. You may need to do the drainage yourself. It's one of the critical skills that doctors or residents should learn. Differentiating pericarditis from acute coronary syndrome, both present similarly, both have chest pain. In pericarditis, it is more sharp, more pleuritic. In acute coronary syndrome, patient will say it feels like there is an elephant sitting on my chest, or feels like there is pressure on my chest. In pericarditis, pain is worse when patient lays supine. It gets better if they lean forward. In acute coronary syndrome, pain is exertional, does not change with position. Fever, history of viral prodrome may be present. Diaphoresis, nausea, dyspnea, these are seen in acute coronary syndrome. You would hear friction rub, but not in all patients. ECG will show regional ischemic changes, but in pericarditis, ECG shows diffuse ST elevation plus PR depression. Troponin rise and then fall in myocardial infarction, but in pericarditis, they may not rise. For safety purposes, if you're not sure if it's pericarditis or acute coronary syndrome, manage it as acute coronary syndrome while you investigate, and then once you determine that it's not acute coronary syndrome, you can lean towards pericarditis treatment. Now, for non-cardiac causes, remember this. GERD or gastroesophageal reflux or esophageal spasm, pain is usually burning. It happens most often after eating. Patient will give you a history of reflux or regurgitation and may respond to antacids. Costochondritis, pain is very localized and it is reproducible with chest palpation or tenderness is present on the chest wall. Pneumonia or pleurisy, patient will have fever, cough, pleuritic pain, and focal lung finding. For example, in pleurisy, you may hear pleural rub. In pneumonia, you would hear crackles. Anxiety in panic attack, chest pain feels more like tightness, and patient usually hyperventilates. They can have paraesthesias like numbness, etc. And this is a diagnosis of exclusion. So if you're saying patient has chest pain, it is likely panic attack without doing ECG, without doing troponins, without doing investigations, you are endangering your patient. Now for OSCEs, remember, even if pain is reproducible with chest palpation, we still consider ACS. We do not say, oh, pain was reproduced by chest palpation. Patient doesn't have acute coronary syndrome, they have costochondritis. Now, when do we discharge patients with chest pains? Their symptoms resolved or improving, vitals are stable, serial ECG and troponins are reassuring, and no high-risk features are present. So we do a discharge, or we can send the patient home and ask them to follow up with family doctor, or do expedited follow-up with a cardiologist. Now, what would you tell the patient if the patient is going to be discharged despite having or coming in with a chest pain? You can phrase it as, your tests today did not show a heart attack, or we still take chest pain seriously, symptoms can evolve. We arranged follow-up and further testing if needed. Tell them about red flags to look for, or when they should return. Return immediately if chest pain returns or worsens, shortness of breath, fainting, weakness, sweating develop, new neurological symptoms, any concern that symptoms are changing, please come back so that we can rerun the test. Now, when you're entering the doorway, so remember to do this in order. Look for ABCs, vitals, just the cardiac monitor, IV, ECG, all these things. State that you're going to look for acute coronary syndrome, pulmonary embolisms, aortic dissections, tension pneumothorax, etc. The 6 can't miss diagnoses that we already talked about. Take a focused history, OPQRST. This sounds more natural when you're taking history for chest pain. If you are not used to this structure, use whichever structure is more natural to you so that you maintain your flow. Assess the risks, medications, specifically phosphodiesterase 5 inhibitors. Do a focused exam, vitals, lungs, heart, pulses, BP in both arms and in legs if you think it would yield positive. Investigations, ECG, it's to be done serial, not just one ECG, serial troponins, chest X-ray, and imaging for pulmonary embolism, which is CT angiography, or for acute aortic disease. For both, we do CT angiogram. In one case, it would be aortic CT, and then in the other, it would be pulmonary. Immediate management is based on what the patient has. If they have STEMI, activate STEMI. If they have other condition, activate the other conditions pathway. And if they have pneumothorax or tamponade, treat them urgently. All right. Now, when we admit or consult or discharge, we do this with safety net or follow-up. We admit patients who are high risk or moderate risk. We consult other physician if they're high risk or moderate risk, depending on what our findings are. Discharge is only for low risk patients who we would tell to come back if symptoms change, their chest pain returns, it gets worse, they start feeling short of breath, they feel numbness, new numbness or new tingling in their arms, anything that changes, they need to come back. Now, take home messages for IMGs, ECG to be done within 10 minutes and repeat every 15 to 30 minutes if symptoms persist. Verbalize the can't miss differential. You have to tell the examiner that you know what you're looking for. Troponin, high sensitivity troponin are to be done in a series, not just one, and look for the delta or the sudden abrupt jump in the troponin levels, and use structured risk tool like HART or any other that you are comfortable with or your hospital uses. Activate STEMI or pulmonary embolism or aortic syndrome pathways, depending on the area where you're taking the test. treat pneumothorax tamponade directly, clinically without waiting for imaging. And remember that high marks come from clarity. If you're clear what you're doing, you're confident what you're doing, you're prioritizing safety first and safety netting, you're going to score high on that station. That's basically what the expectations are from IMGs who want to take the NAC OSCE exam. We're going to discuss how are we going to take history from someone who is presenting with chest pain. Can you see my new screen?
Yes.
Okay. Now we discussed approach to chest pains, how we are going to approach chest pain. Now we are going to discuss it in details, how we are going to take each step. The goal for chest pain history or for chest pains in OSCEs is to make sure that IMGs are ruling out life-threatening causes first, and they are building focused differential diagnosis based on patient presentation, not just randomly throwing in diagnosis that comes to their mind. And IMGs are patient-centered. They communicate in a way that patient understands them and feels comfortable with. And IMGs are efficient in gathering information, 8 to 10 minutes. This is for real life. In exam, you will get 4 to 8 minutes. So we are going to practice on how we can take or get or elicit history of chest pain in 8 minutes. Now, objectives for this slideshow is that IMGs at the end of this slideshow, they should know how to use the OCD, PQRST, UV, AAA framework for taking history from a patient with chest pain, identify red flags associated with chest pain, differentiate cardiac from non-cardiac chest pain, focused associated symptoms, cover these, narrow the differential diagnosis based on your history, and confidently summarize to the examiner what your findings are. First thing first, when you're entering the station or opening the station, wash your hands and introduce yourself. Nowadays, the liquid alcohols that we use for sanitizing hands is more common than washing hands. Washing hands was used previously, but nowadays it's alcohol rub that you use to sanitize your hands. Knock on the door, go inside and greet, sanitize your hands, hand examiner your card, introduce yourself. My name is Dr. Faz. I'm one of the emergency resident. I'm going to talk to you about your chest pain. Is that okay with you? Now, in this one sentence, I introduced myself and got patient's consent. Once I get the consent, I will ask them to tell me about their full name and date of birth. If they are comfortable, they're going to say yes. And then ask them, are they comfortable enough to talk, or do they want me to give them something for the pain? If they say they're comfortable, we will continue with our questioning. But before we continue with our questioning, assess patient stability. Now, they may give you vital signs on the instructions. If they do, look at the vitals, look at even the slightest hypotension. If it's even 89 over 59, think that patient is going into shock. Don't say, oh, it's close to normal, so I'm not going to worry about it. Worry about it. Look at your patient during this 2-3 sentences that the patient says. Are they able to speak without getting short of breath? Are they getting in distress? Are they apparently in distress? Are they blue? Are they cyanotic? Are they sweating? Are they unable to speak? Do they have any confusion? If patient is unstable, you see that the patient is in severe respiratory distress, patient is sweating profusely, unable to speak, or confused, or in shock, or unconscious. Verbalize, I would like to call for help immediately while continuing the assessment since patient is unstable. Do not say, I'm going to try to take history from the patient who is unstable right now. If patient is stable, continue with your history taking. You can start like this. I understand you have been having chest pain. I would like to ask you some questions to understand it better. Or you can say, what seems to be the problem? Or Tell me more about your chest pain. An open-ended question. This will open up the conversation. Patient is going to say, oh, I started feeling chest pain. Now we're going to discuss how to apply the OCD structure here. In OCD, the O that we use, it stands for onset. When did the symptom started? What was the patient doing when it started? And did it start all of a sudden or gradually got worse? Now, when did it start? This is going to give us an idea of what the possible diagnosis is, and it is going to guide our treatment plan. What was the patient doing? Did it start on exertion, which could point toward ischemic heart disease? Did it start after a trauma, which could point towards pneumothorax? Did it start all of a sudden without any warning and got to maximum intensity? Then that means it is acute, probably acute aortic syndrome, like acute aortic dissection. Now, examples, my chest started hurting while climbing stairs. Now, this chest pain started on exertion. It is likely to be from ischemic heart disease. It woke me from sleep. Now, prinzmetal angina is a type of angina that wakes patients up from sleep. Another possible differential here would be GERD. GERD patients, they eat dinner and 2 hours later, they start feeling burning sensation and wake up from the sleep. Or they start feeling chest pain or abdominal pain, they wake up from the sleep. This is another differential, but these are going to, these three questions, they are very quick to cover. They help a lot in determining what's the cause and what are we going to do next. These questions, they will help us differentiate or narrow down our diagnosis to acute coronary syndrome, aortic dissection, pulmonary embolism, musculoskeletal pain, GERD. Patient will say, oh, I was lifting something heavy and then I started, heard a pop in my chest and now it's hurting a lot. So that is a sign that patient may have a musculoskeletal sprain or musculoskeletal pain. Of course, how has the pain been behaving since it started? Did it get better? Did it get worse? Did it stay the same? Ask from the patient directly. How has the pain been since it started? Did the pain get worse, better, or has it stayed the same since it started? Chest pain that starts on exertion and improves on resting, it is likely to be angina, stable angina. Pain from acute coronary syndrome usually does not improve with rest, stays constant and severe. Duration of the pain. Now, again, we already asked when the pain started, but we are going to ask the time frame, like 30 minutes, 40 minutes, 50 minutes. How long has the pain been going on? This will guide our next steps. If it is an acute coronary syndrome and we ask how long has the pain been going on, the patient says 30 minutes, then they are within the window of 90 minutes to do a primary PCI if it is steaming. Position or where the pain is. This helps in identifying pathology. Now, acute coronary syndrome, pain is usually felt behind the chest wall or behind the chest. They would say that feels like someone is squeezing my heart. There is a pressure on my heart or on my chest. How would we ask it? You would say, where is the pain located? Or can you point to me where it is hurting? Patient are going to say, oh, it's hurting all over here. If they say like it's hurting all over here, this means that patient may have acute coronary syndrome because they are unable to localize the pain to one particular area. Second question to ask in P or position is body position or patient's position. How does positioning affect it? Does the pain get better on bending forward? If it does, it is suggestive of acute pericarditis. Quality. What does the pain feel like? Some typical associations, pain that feels like a pressure. This usually is from acute coronary syndromes. Pain that is burning, it is likely to be from GERD. Sharp pleuritic pain, it is pulmonary embolism, sometimes pneumonia or pleurisy. Tearing chest pain, this is aortic dissection. These are some of the associations. If patient has chest pain typical to any of these, think of those as your top differential. Radiation of pain. Is the pain shooting anywhere else? Ask the patient Does the pain shoot anywhere else, or you can say, is the pain radiating or going anywhere else, shooting anywhere else? Most patients would respond to this. If you use radiating, some patients may not understand it. So it's better to say, is your pain shooting anywhere else? They would say, yeah, it's going all the way to my left arm or to my jaw. That means patient likely has acute coronary syndrome, because chest pain with acute coronary syndrome usually radiates to the left arm and jaw. Aortic dissection pain, it goes to the back. Severity, how bad is the pain? Or how severe is the pain from 1 to 10? Then you can explain to them what you mean by 1 to 10. 1 means a very mild discomfort, 10 means the worst pain that you can ever feel. Ischemic pains, they are coming from potential death of tissue. So they are 10 out of 10 pains. Usually patient will say it's like a 10 out of 10 pain. Timing, is the pain continuous? Is it episodic, like it comes and goes? Worse at a particular time, like night, worse after meals? Does it have any relation to exercise? These are the questions to ask in timing. If patient says my pain started 30 minutes ago and it has been continuous, this could be an indication that patient has acute coronary syndrome. If patient says that my pain starts suddenly and then it stops, if it is on exertion, it could be angina. If it is without exertion, for example, a young woman with chest pains at night, think of prensametal angina, which causes pain at night or the middle of the night or early morning. If pain is worse at night, it could be GERD or again prensametal angina. If pain is worse after meals, it's likely to be from GI origin, like peptic ulcers. Pain that happens with exercise is likely from ischemic heart disease like angina or from unstable angina. Now, remember this pattern. Pain that starts on exertion, it is angina. Chest pain in the middle of night or early morning in young women, this is prensametal angina likely to be. Pain after meals, at night after meals, it is to be likely to be from GERD. If someone has constant chest pain after a flu-like or a viral upper respiratory infection, think of pericarditis or myocarditis. Now, the next letter that we use in the OCD structure is U, or understanding of patient. What do you think is causing the pain? Always ask this question. Sometimes patients will point towards things that you didn't even consider in your differentials, and the whole history will start making sense then. So ask this question. It is very important. It reveals what the patient is concerned about. It may uncover patients' hidden anxieties or misconceptions about their pain or their condition. And it shows that you care about the patient. You are asking them about their opinion or what they think is going on. So what do you think is causing the pain? Patient would say, I'm worried I'm having a heart attack. So if they say, I'm worried I'm having a heart attack, it means that they may have had something similar in the past, or they may have experienced, or they may have seen someone experience something similar, and trace their symptoms back to what they saw or what they heard, right? Now, we in structure stands for values, impact, déjà vu. Ask the patient if they have had a similar episode in the past. This would be your déjà vu. Déjà vu means something that you see and you feel like it has happened before. This is like a basic description of déjà vu. So ask the patient if it has happened before. Now, patients who have stable angina, they would say, oh, yes, it happens when I exert myself. Then I have these small tablets that I keep under my tongue and they help. Ask about how it impacts them, or how has this affected you? Is it affecting your work or school? Usually this question is for things that are more chronic. For acute pains, you can still ask, but I would skip it personally. And value, what does the patient value the most? What worries you the most? What do you want to get from this appointment? What is most valuable to you right now? Patient would say, I just want to live. I just want the pain gone. I just want to know what's going on. All right. Now we're going to go into A and A, the 2A aggravating factors, alleviating factors, what makes the pain better, what makes the pain worse. Pain worse on exertion suggests ischemic heart disease. Pain that is better on rest suggests angina. Pain better on bending forward suggests pericarditis. Now, this is where I don't like this OCD-PQR STUVAA structure, because I typically prefer asking this question with P. You can also say P is for palliation and provocation. Ask patient when you're asking them where the pain is. Oh, it's in my chest. Is there anything that makes it better? Yeah, I've noticed staying still, bended forward makes it better. That way, this sounds more natural. If you want to use this structure, there is nothing wrong with using this structure. I personally prefer OPQ or STUV. Okay. Now, associated symptoms. Associated symptoms, cardiac or symptoms that may point towards cardiac pathology, shortness of breath, sweating, palpitations, syncope, nausea. These are things that would point towards cardiac pathology. Respiratory symptoms like cough, fever, hemoptysis, they point more towards pulmonary or a lung problem. GI symptoms like heart, burn, regurgitation, these point towards a GI problem. Nausea, vomiting can be seen in acute coronary syndromes too. So nausea and vomiting, I have added it here in GI, but they are also seen in cardiac causes of chest pain. Musculoskeletal, ask about chest tenderness, leg swelling, leg pain. If there is pain on touching the chest, it points towards costochondritis. Does not rule out acute coronary syndrome. Remember, it's just a suggestive of costochondritis, but it's not 100% confirmed. Acute coronary syndrome is not present. Okay, leg swelling, leg pain, ask about them. They may point towards a pulmonary embolism originating from a DVT in the legs. Past medical history, cover coronary artery disease, hypertension, diabetes, lipidemia, at least these four. If you have time, cover history of clots, lung clots, clots in the legs. Don't say pulmonary embolism. Say, have you ever been diagnosed with a lung clot or a clot in your leg? No. Asthma, COPD, sometimes asthmatic can feel similar to just tightness and shortness of breath. COPD again can cause shortness of breath, may cause chest pains if patient has been using accessory muscles a lot. GERD, like reflux, anxiety, ask about genetic conditions like Marfan's. If you haven't already, ask about previous episodes of chest pain and recent hospitalizations and surgeries. This should be covered in the medical history. Now, medications history, ask about prescription medications, nitroglycerin, anticoagulants, birth control pills, hormone therapy. These are some of the medications you should ask about. Nitroglycerin, if patient has taken it, if they have reached the maximum dosage, you may not give them anymore. If patient is already on anticoagulants, then we are going to consider other strategies. If patient is taking birth control pills, it could be a risk for a pulmonary embolism instead of acute coronary syndrome. Hormone therapy, men who are taking testosterone replacement therapy or those who use it for performance enhancement, they can get acute coronary syndrome. Ask about medication compliance. If patient is taking chronic medications for chronic conditions like high blood pressure, diabetes, dyslipidemia. After you're done with the personal history of personal medical and medications, ask about family history. Ask about early heart disease. Women less than 60, men less than 50. If they have had a heart attack, it means patient has a high risk of getting heart attacks. Ask about sudden cardiac deaths. Cardiomyopathies, they do not present with symptoms. They present with sudden cardiac arrest or sudden cardiac death. Ask about history of high cholesterol in the family, disease of the aorta, clotting disorders. For example, did your mom or your dad or your sisters have clots in their legs or lungs? Yes or no? If that, then it means patient likely has thrombophilia and their chest pain is possibly caused by pulmonary embolism. Once you're done with family history, then comes social history. Social history, smoking, alcohol, recreational drugs. Uh, these three have to be covered. We know that it is an emergency, but you have to cover these three. Alcohol can cause alcoholic cardiomyopathy, increase the risk of getting acute coronary syndrome. Smoking can cause acute coronary syndrome, increase the risk of getting embolisms. Recreational drugs, cocaine and amphetamine. Now, these two are very important to cover because cocaine can cause transmetal angina or vasospastic angina. It causes the spasm of coronaries. Amphetamines that can increase myocardial demand and cause demand ischemia or type 2 ischemia, which is when the myocardium's blood flow is not restricted, but the demand is so high that the patient's blood supply is not enough for it. Ask about occupation. Sometimes chest pains may be caused by occupations like musculoskeletal pains, people who do a lot of work with their upper body. Recent travel is important to cover in social history because it could lead to DVT or PE history. Immobility, such as surgery, we already covered surgery, but ask about if patient has been recently on bed rest for a few days or longer than 24 hours or 12 hours. Ask about stress. Now, stress is important to us because if maybe patient is having anxiety attack due to stress in their life, sometimes, especially in younger patients, when they are under extremes of stress, they can present with acute coronary syndrome like symptoms, and their ECG, etc., would be normal, but they will still have the chest pain that is typical to that with shortness of breath, etc. Sometimes if someone has recently received a bad news, they can get something that we call broken heart syndrome or Dr. Sobo's cardiomyopathy. It presents with acute coronary syndrome, STEMI-like ECG changes, even troponins could be high. But once you take them to cath lab, there is no coronary blockages. These are some of the red flags that you are not supposed to miss. If patient says they have crushing chest pain, this is a very important thing to note that this is likely from the heart. Pain radiating to the jaw or arm, this is acute coronary syndrome until you prove it otherwise. Severe dyspnea, it is either cardiac or pulmonary, but both are very important to follow up quickly. If patient had syncope, it could be massive pulmonary embolism or acute coronary syndrome. Hypotension, it could happen with right ventricular infarct or with tamponades, tension pneumothorax. Sweating or diaphoresis, it happens in patients with acute coronary syndrome, sometimes those with anxiety too. Hemoptysis is very important. Patients with pulmonary embolism will have hemoptysis, but it's a late finding. If patient has a sudden tearing pain, think of aortic dissections or acute aortic syndromes. Unequal pulses, again, aortic dissection. Neurologic deficits, think of, again, acute dissections. All right, this was how to navigate chest pain and how to take history of chest pains in your neck OSCEs.